Victoria Baldwin, and this is my final presentation for my Health 698 internship with Catholic Charities in Atlanta, Georgia, with refugee resettlement. Next slide. So the problem that we were seeing and what I was brought on to help tackle was the large perceived gap in culturally appropriate and comprehensive medical care existing among refugee clients in the Atlanta metro area. So part of my internship was to determine the appropriate method to conduct a needs assessment that would also help with one of the grants that was just approved to help build an educational program for Catholic Charities to help target medical providers, as well as developing just the educational program as a whole. So the goal was to conduct the needs assessment and analyze the data and start developing a framework for an educational program that could be used later on to help target medical providers, to help them learn how to provide culturally appropriate and competent medical care. So the long-term goal in all of this not only is to develop the educational program that can be used to reach out to, ideally, all medical providers in Atlanta, but also in hopes of improving the quality of care that refugees are receiving. Next slide. Some demographics considerations that were important during the study were the level of literacy for the refugee clients, whether or not they could speak English, whether they needed a translator, whether they could read English or even their own language in some cases. Another consideration is that Western culture is not very community-minded, and in a lot of other cultures where refugees are coming from, there is a community-minded mentality, and so that impacts medical care as well as all other aspects of his or her life. Religious considerations are also really important to take into account whether or not he or she can have certain medical procedures because of religious backgrounds, whether it's allowed or not, and that can influence the treatment plans and medical decisions. Another factor is trauma, whether it was in country before they became refugees and came to the United States, or even in some cases, the trauma that occurs leaving their home country to move to the United States. Some of these examples are post-traumatic stress disorder, anxiety, depression, suicide, and mental health awareness, and in some cultures are very untalked about and taboo topics. And so these, while still extremely prevalent in those communities, may not be understood for what they are known as in the United States. And so that is an area of education that needs to occur on the medical provider side of things so that they understand where a refugee client might be coming from culturally. Another big factor was the Afghan refugee crisis that occurred in August that helped really bring to light more of the conversation of refugee resettlement. And I came into my internship right as this was all occurring, and so it really did shift the way that I would have traditionally learned and grown in refugee resettlement to being way more adaptable because there was so much changing on an everyday basis. Next slide. There were a total of 10 participants in our studies. We had 5 case managers that worked for Catholic Charities, and then we also had 5 refugee clients who were part of the refugee resettlement program that Catholic Charities runs. They were of Congolese and Afghan origin, and there was a total of 6 males and 4 females. They were participating in interviews and surveys, and they lasted around an hour. Some were over Zoom and some were in person, just based on comfortability and COVID considerations. And the data collected from both the interview and the surveys, as well as case reports, were formulated into a needs assessment and analyzed with 2 sample t-tests and 2 sample z-tests to get the p-values to determine the statistical significance to conduct that needs assessment. Some of the open-ended questions were what we used to help develop the framework for our educational program for where we needed to do more research and hone a little bit more in for when we're working with medical providers, because that's where the perceived gaps are at this moment. Next slide. So the results of our needs assessment, our original hypothesis was that there's a correlation between medical providers treating refugee patients and inadequate medical care and culturally appropriate care. So the 2 sample t-tests were some of the closed-ended questions that rejected the null hypothesis because the p-value was less than 0.05, which proves statistical significance. And then this 2-tailed z-test analyzed whether or not a patient had ever left a medical appointment without being told a diagnosis or given a care plan. And the p-value was 0.0072, which is less than 0.05, which proved the statistical significance and that there was a significant gap in whether or not they were given a diagnosis and care plan. So our open-ended questions helped show that there was a lack of translator availability, coordination between medical providers and translators. There were mental health concerns, whether or not educational material was in the appropriate language, and even some issues with understanding of how healthcare works in the United States and pharmaceuticals, and where in certain countries of origin they may not have ever had to pay for medication that are necessary for them to come to the United States and be told that they have to pay for this medication and they do need it, and medical providers not explaining why was something that was very much talked about. The next slide. So some of the big learning opportunities I had was that overall I had a relatively limited knowledge from where I started to where I am now of refugee resettlement and really what all that entailed. And with the Afghan refugee crisis, it's brought a lot more of refugee resettlement to the surface of public health and more topics of conversation in everyday life for, I think, a lot of Americans. But it really was a very fluid situation. And so I was adapting and learning, and even people that I was working with who had been in the field for 10, 15 years were learning new protocols and new policy changes, whether it be with the Afghan parolees who didn't come in with documentation or at the time any plan for medical care, or SIV applicants, which are special immigrant visas that typically take longer and more background before being allowed into the United States, coming in immediately so that they were safe out of harm's way, which was fantastic. But it also meant that the proper documentation didn't make it to us. And so how to proceed and get medical care and enrolled in the right government programs and get children enrolled in school on the timeline when the medical system is a little bit inundated with the sheer volume of refugees and lack of medical providers who are capable or willing to treat these patients. Clarkston, Georgia, is one of the largest refugee communities in the metro Atlanta area, which I learned. And in this community, there are restaurants and grocery stores and, just normal everyday shops that are either run by former refugees or people who came into the community and want to invest in that community. I learned about the halal grocery stores that were specifically in these areas and restaurants that, followed that diet so that it was culturally appropriate for a lot of the refugees incoming, which in a lot of the other areas of Atlanta, that may not occur. Like I mentioned, some of the really big issues were lack of volume of medical providers able to treat refugee clients. Some of our limitations were that there was a small pool of participants because Catholic Charities is a smaller office. COVID-19 really made a big impact on what we were able to do overall. There was a lack of translators, and it's not a comprehensive study of all of the refugees in the entire Atlanta area, and so a consideration would be to have a larger study later on. Next slide. And some continued develop will be finishing that educational framework and working out the medical providers list and figuring out more of the Afghan parolees and what medical coverage they have. While that is still being worked out right now, that would be a larger consideration. And another one would be case manager training specifically for mental health and post-traumatic stress disorder, because that's becoming such a large issue within the refugee community. And a lot of the case managers were mentioning to me that they didn't feel prepared because that's not something that they've been trained on, and I had some background in, so I had the opportunity to share some of my background. next slide is my references.